All right, let's get started. Good morning and welcome to Grand Rounds. It's my pleasure to welcome you this morning. And as always, we're going to start by pointing out some of the upcoming Grand Rounds so you can save the date and share this information with your colleagues. So next week, we'll have a presentation on the landscape of antibiotic resistance in the United States. The following week, we'll have our twice annual quality improvement series with participations from pediatrics and pathology and neonatology. Next slide. Just want to make sure everybody knows how to get your CME credits, and please take note that the text code, there's a new text code every Friday. So there it is. We'll put it in the chat box so you have it at your fingertips. And then very, very important town hall that I want to bring to your attention. The Stanford Pediatrics Advancing an Anti-Racism Coalition has been doing extraordinary work since June, co-chaired by Lisa Chamberlain and Lahia Yamani, but just an extraordinary participation among our faculty, staff, and learners. We've dedicated significant resources to implementing every action item that they've brought forward, and they'll be sharing those details on Monday. So please be sure to join us. Next slide. And this is, another really important contribution from our faculty is the COVID-19 in Children seminar series that will complement our Grand Rounds, but Thursday from 1 to 2 p.m. Very distinguished lineup here with Bonnie, with Phil Fizo, our former dean, and with Charles Prober from infectious disease. And next slide. And these are the groups of faculty and other experts who've helped put this seminar series together. Thank you and congratulations to Alan Schroeder and Roshni Matthews for all this work. And then also thank you to the outstanding committee members. And you can see we really have great representation from pharmacy, the community pediatrician, and many of our subspecialists that have been really on the front line of treating these children. Next slide. And then back to the theme on the diversity, we're going to just want to make sure everybody knows about the Diversity and Inclusion Forum. This is highlighting innovative workshops that have been developed by our residents and fellows and is part of the larger LEAD program, which, as I'm sure you know, got the University President's Award around Diversity Annual Award this year. All right, and with that, we will move on to our welcome our speakers. Bonnie has given multiple Grand Rounds, and the first time we had her here, right as this started, I think I spent about 5 minutes telling you all about Bonnie, but I think now she needs no introduction. Very briefly, she's a professor in our departments of pediatrics and health research and policy. She's chief of the Division of Infectious Disease and senior associate dean of faculty development and diversity. From the very beginning, our dean really said that Bonnie is on point to lead all of the COVID activities across the campus. Amazing work just in the first few weeks out into the community and doing population-based studies on transmission, and her long-standing research interests are epidemiology and prevention of viral vaccine preventable infections, such as measles, polio, rotavirus, have been conducted internationally, really worldwide. As Bonnie once said to me as this was starting, she says, I've trained my entire career for this as we went into COVID. She's a fellow of the American Academy of Pediatrics, the Infectious Disease Society of America. She's a member of the Society for Pediatric Research, the Pediatric Infectious Disease Society, and the American Public Health Association, and also leads the Red Book. We also are very fortunate to have Roshni Mathew join us. I'm sure you all know that Roshni has been the clinician absolutely at the forefront with her fingertips on the pulse of every patient that has come into our hospital. She's a clinical assistant professor in pediatric infectious diseases here and co-clinical chief for the division. Importantly, she's the associate medical director for infection prevention and control at Lucile Packard Children's Hospital. And in this role, she oversees medical direction of the infection prevention and control activities with experiences in outbreak and exposure management, emerging infectious disease preparedness, leads healthcare associated infection prevention activities with a recent emphasis on CLABSI. More recently, she's been intimately involved in the development of guidance around COVID-19 and operationalizing these at Packard, and has made herself available to all of our clinical chiefs and medical directors just about on a weekly basis for phone calls, where she absolutely keeps us updated on the rapidly changing guidance. So with that, Bonnie, we'll go ahead and get started. Welcome.
Great, thank you, Mary, for that introduction. And so this will be a two-part discussion. I'm going to start it off. I just want to say that I am a member of a data safety monitoring board for a Pfizer vaccine, a non-COVID-19 vaccine. And at least my objectives today, Roshni, will have separate ones. I'm going to talk a little bit about transmission in daycare centers, COVID-19 disease and testing in colleges and universities, clinical manifestations in young adults 18 to 34 years of age, a very brief update on the SARS-CoV-2 vaccine field so far, and issues around health disparities and COVID-19. So there is a recent article came out last Friday in MMWR looking at transmission dynamics of COVID-19 outbreaks associated with childcare facilities in Salt Lake City, Utah. And while this is a small outbreak, I think what it really did let us understand is the dynamics of transmission, and really did, contrary to what others have been saying, we definitely can, which we understood before, but now we have proof, additional proof that children can transmit disease, but we've also have some lessons around how to prevent that. So this on the right is a figure showing 3 daycare centers in Salt Lake City that were part of an ongoing series of outbreaks that occurred in each. And you can see here, there is a very small daycare center, a medium one, and a larger daycare center. And these were outbreaks that occurred in centers that had children 3 months to 16 years of age, with the median age being 7 years. It's hard to read this figure here, but I think I like the idea of seeing this disease spread. So this is actually the daycare center in the center here. And then these are all household contact cases, so outside of the facility. So you can see that the majority of exposures and cases really did not occur in the healthcare setting, in the daycare setting itself, but children were infected and brought it home, and others as well. So there were 31 cases of COVID-19 that were demonstrated among 184 people linked to the facilities, that is either staff, children in the daycare, or contacts of the children or staff. 18 cases occurred in adults and 13 occurred in children. 9 of the cases occurred in household contacts of the children, and an additional 7 probable cases where there was no testing also were noted. Now, it's important to note that the vast majority of cases, contacts of cases, did not have testing, but also were not symptomatic. So we're missing data for about 58% of people for whom no testing was done because they had no symptoms. Now, it's interesting to note, of the 13 children who were infected, most had either 3 had no symptoms, and the other 10 had mild symptoms, mild fever, headache, or sore throat. And there was transmission from 12 of the 13 children. 26% of the children, there was a transmission to 26% of the cases. 26% were in household contacts. And interestingly enough, 2 asymptomatic children infected transmitted to household contacts, including 1 in a mother who was subsequently hospitalized for her infection. And interestingly here, this epidemic, this little outbreak here, the smallest one, and then this one here is the medium one, involved only 2 staff, and this one involved 5 individuals. And the one that involved 2 staff up here, the staff member infected probably exposed the other staff member, and that was the extent of the outbreak there. But the staff member who was the index case actually was a secondary contact of somebody who lived at home who had symptoms, and the staff member did not isolate themselves while they were in the incubation period for exposure to that symptomatic person at home. To be fair, that person did not know they were sick, but they also knew they were infected, but they knew they were sick. And then same thing happened here in the second daycare center, where the staff member was infected at home. than infected individuals at school. In the third larger outbreak, there was one daycare staff member who was infected. We don't know the source, but nobody in this daycare center, surprisingly, was wearing masks at all, neither staff nor children. So the spread here was really likely because of lack of masking. And so I think we can learn some lessons about how to prevent disease. That is, if you are a staff member, if somebody at home is sick, you're supposed to isolate yourself for 14 days until you are either develop no symptoms, or if you're symptomatic, you're tested and positive. So we could have avoided all three of these outbreaks in one way or another. So this conclusively establishes, contrary to what you're hearing on some of the media outlets, this establishes the ability of children of all ages to transmit SARS-CoV-2, including an 8-month-old child who spread the virus to both parents. We don't have the clinical status of that child, but as I said, none of the children were severely ill. One asymptomatic child infected, two asymptomatic children infected adults and child household contacts at home. And temperature monitoring, symptom screening were not sufficient to prevent outbreaks, but remember, most of the outbreaks occurred from people who were already exposed to symptomatic individuals and should have been isolating, or work occurred in places where no masks were being used. And that without masks was the most extensive outbreak. Now, it is also likely that some asymptomatic cases may have been underestimated, since 58% of the contacts weren't tested because they had no symptoms. So we really do think that this demonstrates definitively that you can transmit. Children tend not to get as sick, but there are really easy methods to prevent transmission within daycare centers, which people think would be the most likely place to transmit because of the high exposure to secretions of children. I'm not going to spend a lot of time on the college data. This is really just, the New York Times seems to be the best source for all these cool graphics. But you can see here that earlier this week, and New York Times put together a whole article about why people are getting infected at colleges. I think you can all figure out why that might be. But basically, they're gathering in large groups in some schools and not in others. And you can see that there are over 88,000 cases so far in colleges and universities over this period of time. And you can see the dots of schools for where cases have been identified. And the density of the color really reflects the number of cases that have been identified. Some of these have led to school closures and all virtual settings. Now remember, there's also a number of schools that haven't gone live. So that is, they're doing virtual school classes. So the 88,000 is particularly important because that doesn't include, for example, the California State University system, which is the largest public system in the country, and decided very early on to go completely virtual. So we are pulling a lot of large college populations out of this, and you're still seeing quite a number of transmissions. This is a really interesting non-peer-reviewed paper. I put the reference down on medRxiv, not peer-reviewed yet, but I thought it would be interesting data. This particular group from the Brigham assessed COVID-19 on-campus testing plans. So what are people doing at over 500 US colleges and universities? And what they saw, and was disturbing to them, highly variable testing plans with discrepancies between scientific studies and federal guidelines. And part of that has to do with the fact that we have no national approach to how do we do any of this, including opening colleges or going back to school for younger kids, or sports, or anything else that's relevant to this pandemic. Divergence between university testing plans and public health best practices and bioethical issues came up, and I'll show you that data in a bit. So it turns out that of this assessment that these investigators did, 54% of the universities they polled had some form of COVID-19 testing, but only 27% of colleges with initial re-entry testing. Remember, when you're coming back to school, you're bringing in whatever your community transmission looks like. So that to me would be the most important thing to do. If you only had one time to test, I would test when people are coming back to school, because they may be asymptomatic or maybe pre-symptomatic and maybe bringing back infection into a semi-bubble. It's not truly a bubble, but at least you're screening people who are coming back who might be reflecting their local epidemiology. And 20%, only 1 in 5 schools were planning to test their university or college communities on a regular basis. This is another part of their study. With again, this is where the bioethical issues come up. You can see this slide here. Apologize for the quality, but this is really the university testing. How many schools are going to be testing initially based on the positivity rate in their state. And you can see that New York and Massachusetts had the highest testing frequency based on their very low positivity rates, presumably because they had high infection rates early on. But you can see that current states with very high positivity rates here, Pennsylvania, California, and Texas, had very low overall testing on entry rates. And presumably some of that might be due to a lack of access. In this particular graph, you see the average amount of testing frequency, and this is in weeks of all of the schools tested. So a large block, we're only going to be testing maybe twice a month, some once a month, some, and the median was 1.34 week. I'm sorry, once a week, 1.34 weeks. And then there's a whole block that are testing twice a week. And you can see here that this is an interesting slide. This is percent of the endowment of the institution and whether or not they, yes, are going to be testing, or no, they're not going to be testing, or unknown. And you can see that there's there's correlation between the endowment of the university or college and whether they're going to be doing entry testing. So we can clearly see there's a resource issue here. So schools with higher endowments were able to afford or offer entry testing. So we already see a disparity there. There's a geographical bias, and that in large extent is driven by these two states, Massachusetts and New York, where have a very strong relationship with the Broad Institute, who has a very rapid and sensitive and specific PCR test that they're offering to schools in the Northeast. So that really skewed this data here. So the Broad was able to offer testing to a lot of colleges and universities. And then you can see again that those states with the highest positivity rates here were the least likely to be testing upon entry. So there are some disparities there, and that speaks to the issue of really trying to build a national approach. Now, I'll just show you, and the link is down below. It's healthalerts.stanford.edu. This is our testing dashboard that we've been working on, building the school reentry since probably June with the Provost Task Force. And this is our nice dashboard that we can see. These are the number of tests from June 29th to the present, and this is updated once a week. This was last updated on June 11th, or September 13th. And you can see that there have been a total in students of 13,000 cumulative tests conducted, with only 27 positive tests since June, and really very few tests that have been positive here. Both of these were people who came in and were positive upon entry, are now being isolated. So the system is working as it's supposed to be. Among staff, you're seeing that this is obviously the students, this is student testing is mandatory on a weekly basis, and faculty testing is not mandatory. It is optional, and you can see that there are no positives so far among the faculty. So you're welcome to look at this on a weekly basis or anytime, and it's updated weekly. Now, if we look at overall COVID-19 outcomes in young adults, this is a study that came out of JAMA Network earlier this week of over 3,000 young adults, 18 to 34 years, out of 178,000 individuals who are hospitalized, so representing about 2% of the overall population, to really emphasize that young people are, yes, they are at lower risk of developing disease or severe disease, but even in this group of hospitalized individuals, 21% required intensive care, 10% required mechanical ventilation, and 2.7% died. And you can see here on the right, this is, these are the young people. This is based on comorbidities, which primarily include morbid obesity, hypertension, and diabetes. And that this is 0 risk factors, 1 and 2 or 3. And the dark bars are death, and the light bars are mechanical ventilation. And these numbers are deaths. The dotted lines are deaths and mechanical ventilation in an older cohort, 35 to 64 years of age, of middle-aged non-pregnant patients with no conditions. So you can see that in general, young people have lower rates of disease, death or mechanical ventilation than that population, except when it comes to those with 2 or more comorbidities, where their death and certainly their mechanical ventilations at least reach or exceed those of older adults. So we know that young adults are still at risk for serious illness. Granted, the proportion is smaller than in older adults, but comorbidities clearly drive a lot of that. And more than half of those requiring hospitalizations were Black or Hispanic. And I want to just leave you, before I move on to the next piece, these slides will be available to you, but please always visit the aap.org website. You don't even need to remember your ID member number to get into the COVID-19 section, which is always annoying when you try to go there and you have to find your ID number and enter it. You can just click on and find resources, and families can find resources at the bottom of the page through the healthychildren.org link. And there's lots of guidance there on PPE, testing, flu shots, anything you want to find out about children. Now, I want to talk a little bit about the convergence of crisis confronting simultaneous pandemics. And when, of course, I'm talking about the pandemic of SARS-CoV-2, but also the pandemic of racism and racial and other socioeconomic health disparities. And this is one of my favorite books, written by Bill Hayfage, a CDC-trained epidemiologist who was really one of the people responsible for eradication of smallpox. And he said, if a house is on fire, no one wastes time putting water on nearby houses just in case the fire spreads. They rush to pour water where it will do the most good on the burning house. And I think this really relates not only to SARS-CoV-2, but also to the epidemic of racial and ethnic disparities. We don't walk around, yes, all lives matter, but right now Black lives matter because they are on fire. And we need to focus on them. It doesn't mean the other houses aren't important. It means that these houses are going to come down in flames if we're not careful. So this is a really exciting way for me to look at it, because this is how we approached quantitatively an infectious disease that was eradicated on the face of the earth. And this is going to be one way that we can start to address some of the other problems in our society today. You can see that when you look at COVID data by race and ethnicity, it's very clear that cases, hospitalizations, and deaths are disproportionately higher in all of our underrepresented or racially and ethnically diverse populations when you look at the reference in reference to white, non-Hispanic, or non-Latinx populations. So clearly, these are not just biologic or genetic risk factors. These are social determinants of health driven by poverty, and other socioeconomic conditions. So when we look at disparities around treatment and prevention at the local level as well as at the federal level, we are really targeting, and certainly in our clinical trials here at Stanford, including our vaccine trials, which will be upcoming, we will be focusing on minorities, people living in rural or frontline areas, those experiencing homeless, essential and frontline workers, and those with disabilities and other risk for increased transmission. And when we look at vaccines, and of course, Grace Lee will be the person who's leading the Safety Commission for the ACIP. There are 4 principles around equity, and one is safety. We have to have extremely high standards for safety of any vaccine or therapeutic that we use, and it has to be safe in all populations, and we cannot be using minority populations under coercion to try to demonstrate safety. Everyone has to be informed and enter these of their own will. We need to be sure trials are inclusive, that people have access to trials from different backgrounds so that we know these vaccines and these therapeutics work in all different groups and that they have access to them. Efficient distribution, especially during a pandemic, needs to be ensured with equitable distribution across all populations, including those that are hard to find. And those networks are being set up now. We encourage those to be really well vetted so that everybody has access when they need it to treatment and vaccines. And then finally, we need to be flexible around the national guidelines, around our local guidelines. We have seen them change over and over, but that's because the epidemiology of this disease changes, and we need to be open to that flexibility and listen to our leadership who have expertise in these areas because this virus really does turn on a dime, and we really need to understand on a day-to-day basis what might be going on, and also to be looking in our communities that have low access, where there may be smoldering epidemics that were, or outbreaks that we are not identifying because they don't have access to testing. For example, tomorrow we'll be spending a day volunteering at the Gardner Clinic in Gilroy to test over 300 farm workers who have never had access to testing or healthcare, so that we can try to identify hotspots there if they exist and get them into care. I'm going to spend just a couple seconds here looking at the global spectrum just to see where we are. It's very clear that this disease is obviously widespread, but we're seeing lots of disease in the Western Hemisphere. Part of that may be due to increased access to testing. We don't know. We know, for example, that India has a very big burden of disease. And you can see here that after the US, India has the second highest number of cases, although they are 4 times bigger than we are at least. So we are still probably the worst off in terms of per capita disease, although we probably are testing more than other places. It still does not, it underscores the degree of spread within the United States. And you can see that while we are doing a better job in terms of managing the pandemic here in the last few months, July was a really difficult month because I think we just kind of got a little bit less careful. We have to be careful now because we had a big holiday weekend. Now the fires may have mitigated some of that, but we're waiting to see if there may be a bump from the Labor Day weekend, and hopefully we won't see any increase in hospitalizations and ER visits because of dual pandemics, that is COVID-19 as well as flu. And then this is around vaccines. I'm not going to talk about the vaccines except to say that we will be enrolling in 3 different vaccine trials. Phil Grant from Medicine will be enrolling in the Janssen vaccine, hopefully starting next week. And Ann Arvin and Jenna Boyke and I will be leading vaccine trials starting in October for Novavax and potentially for Sanofi. And this is really just a quick slide showing how many doses in the billions that each of the companies that will have vaccines in the next year or so are promising. So these are really about 9 million doses total. Remember, there are over 7 billion people in the world, and most of these will require 2 doses. So we really won't have access to 2 doses for everybody, but we will get reasonably close. The colorful bar here is allocations to different parts of the world. And when you look at where they're going to go, we see that the United Kingdom is going to have on average 5 doses per capita. The US will have about 2, and so will the European Union. But if you see the rest of the world, the number of doses per capita is really going to drop off. So we really need to make sure that we're equitable in our distribution of vaccines around the world. And here in the US, we'll be focusing on there's phased approaches to how vaccine will be distributed. Initially, there will be only about 10 to 20 million doses available sometime in late 2020, early 2021. And those will really be focused on frontline essential workers and healthcare workers, as well as people who live in long-term care facilities or work in those places. And then there will be a little bit of a flattening out of doses available for all of those populations. And then with more dosing available, they will be distributed throughout the population. And again, we really need to make sure these are equitably given by within groups of high risk, as well as racial ethnic minority groups that may also have high risk. And then these are the groups, as I mentioned early on, we have over 100 million people in this country with high-risk medical conditions, about 60 to 80 million essential workers, of whom about 17 to 20 million are healthcare personnel, and adults greater than 65-year-olds make up 53 million of the population. So you see the intersection here may be where that very first tranche of vaccines is going to go. And then they will roll out across the rest of these populations and then get out to the whole population, hopefully by, and again, this is assuming we have a safe and effective vaccine in early 2021 or mid 2021. And then finally, because of the efforts and the support of this institution and of a number of our philanthropists and also from NIH support and our CTSA, we've been able to roll out a number of outpatient and inpatient trials, including remdesivir, lambda interferon trials, favipiravir, camistat coming up soon. As I said, we're going to be working on 3 vaccines, and we have a number of planned trials now. Actually, we just enrolled our first patient on a monoclonal antibody study yesterday. We're looking at inhaled remdesivir and other studies as well. So I'll stop there and hand it off to Roshni. Thank you.
Thank you all for this opportunity. And I just wanted to focus a little bit on my experience with several of these aspects with COVID-19 at LPCH, a little bit about our journey from an infection prevention and control standpoint on operationalizing guidance at the Children's Hospital. I would like to briefly talk about clinical presentation in children and management challenges with COVID-19 in pediatrics, as well as a little bit about our LPCH inpatient COVID-19 experience. So infection prevention and control has been a major focus with COVID-19, and a lot of guidance along the way had to be operationalized at LPCH, and we have learned a lot along the way. And I just wanted to describe these in 3 buckets. Challenges with risk communication, impact of being attached to an adult hospital, and ever-changing guidance from CDC, Department of Public Health, etc. A little bit about all 3 of these buckets, and I just want to concentrate on 2 of these in a little bit more detail. But in terms of challenges with risk communication, right from the start, this has been an ongoing learning opportunity. This started with PPE and what is the appropriate PPE we would use. There has been constant discussion about whether SARS-CoV-2 is airborne and what is the mode of transmission of SARS-CoV-2. Aerosol generating procedure is an interesting topic in my mind because prior to SARS-CoV-2, there was not a lot of focus on this specific topic, and we all knew there were certain procedures that are aerosol generating. However, after SARS-CoV-2, what we realized is that everything suddenly came to be looked at through the lens of, is this an aerosol generating procedure? So that was an interesting exercise in trying to figure out the list of what is actually aerosol generating procedure, which is high risk, which is medium or unknown, and which is low and not an aerosol generating procedure. And I will talk a little bit about test positivity and transmissibility a little bit more in detail. And briefly wanted to talk about the other 2 buckets, the impact of being attached to an adult hospital. We all, as pediatricians, know that children are not small adults, and in COVID-19 specifically also, we know that it has impacted children very differently. And so when we roll out guidance, it is actually quite difficult to completely align with the adult hospital. But that has become important because we have shared personnel that go across the two hospitals, as well as shared services across the two hospitals, which I've mentioned here, like laboratory and phlebotomy and supply chain, occupational health, emergency management. So all of these are shared services. And when we have such a lot of shared people and services, it becomes important that we align as much as possible. And that leads to a lot of challenges, specifically when we try to do this in children. And about constant changing of guidance, and this is not new to anybody, that right from the start, there has been a lot of changes along the way. We were told to not mask, then we were told to mask and things like that. But as you can imagine, at an institution level, when we have to roll out guidance and then the next week there is a change in guidance, relearning all of that, trying to get buy-in and all of that is always very interesting. And as you know, this has changed for who to test, how long to isolate, what is the quarantine period. All of these have changed along the way. And so those have been quite interesting from an infection prevention and control, where we have to keep in mind CDC, OSHA, Cal-OSHA, local Department of Public Health. All of these have to be kept in mind when we develop guidance. And I just wanted to talk a little bit about airborne versus droplet transmission and test positivity and transmissibility. The potential for SARS-CoV-2 to be an airborne disease has been entertained right from the start. So in March or April, the New England Journal Medicine paper came out that showed that they were able to show that SARS-CoV-2 remained in aerosols for several hours. And this followed with several other papers that looked at experimental models of how SARS-CoV-2 can remain airborne and potentially have the ability to be transmissible like an airborne transmissible disease. However, we always knew that the R0, which is the basic reproduction number, a mathematical term to describe how many people could get infected from one person, we knew that SARS-CoV-2's R0 is about 2.5. Compare that with measles, which is a known airborne transmissible virus. This R0 is 18. That means one individual who has measles can infect up to 18 susceptible individuals. So very different from SARS-CoV-2. However, what we found along the way is that experimental data come long before clinical data. So that was one of the challenges, trying to figure what does it mean to have it in the air for 3 hours? How does it translate to clinical at the bedside? Keeping up with media, which is so interesting because before you know it, New York Times has already published on something and you're trying to keep up with what exactly is the meaning of it. And to articulate it better than media can sometimes be hard. And keeping up with a large number of publications. This is peer-reviewed, pre-peer reviewed. So it is coming at you with lightning speed. So it is kind of hard to keep up with all of that information and to be able to translate it and to make sense and to be able to get buy-in and get people to understand what exactly is happening. This particular paper came out in JAMA, which actually talks about this specific issue where what is seen in the laboratory may not always be applicable in the clinical world. And so after all the experimental studies came out, there were several other papers that looked at how it translates in the actual clinical setting. So this is an example of this, which this is the first patient that had the community-acquired SARS-CoV-2, if you remember from way back in February in Solano County, where this particular patient had never traveled to Wuhan, so did have respiratory illness, but was not tested because at that time, if you remember, CDC's guidance was to only test individuals who returned after a travel. This particular patient essentially eventually turned out to be SARS-CoV-2, but exposed multiple healthcare providers and resulted in 3 positive individuals. And all of them had prolonged duration of interaction with the patient, who was undergoing an aerosol generating procedure during those times. So this helped, and this was a time when there was no universal masking, personal protective equipment was not used. And so this helped understand what is the risk to healthcare providers in these settings. Thereafter, a few other papers have come out. This is from Brigham and Women's, where a similar older gentleman who was admitted for cholecystectomy 2 weeks after admission, he had developed respiratory failure and was diagnosed with SARS-CoV-2. During that entire time, there was no specific isolation put into place. Exposure, about 44 individuals, and 2 of them tested positive, again with prolonged duration contact with the patient with no PPE on. You might have heard of this particular incident. This is not in a healthcare setting. 2 hairstylists at Great Clips in Missouri worked, excuse me, worked for about 8 to 10 days symptomatic, awaiting their test. So they did not know the result of their test, but there was mandatory masking in the salon. And so the individuals who were infected, as well as all of their clientele, were wearing masks. And this led to a large scale exposure. And those individuals who were tested, all of them came back negative, helping us understand that masking is helpful. All of these examples basically say that although SARS-CoV-2 can remain in the aerosol, it really depends on the situation. It doesn't mean that it's an airborne transmissible disease. In most instances, it does not transmit like measles. And so these are informative from that aspect. In terms of test positivity and transmissibility, I think as an infectious disease physician, this is just so interesting because if you look at influenza, for example, we use the test positivity to make the diagnosis in the patient. Thereafter, we don't keep retesting the patient. It is not associated with transmissibility per se. But however, with SARS-CoV-2, what is so interesting is everyone is very well aware of the testing. And so somehow it has gotten so entangled with the ability to transmit that to disentangle the two has been an interesting conversation along the way. So a CDC very recently, about a few weeks ago, came out with this guidance about how to discontinue isolation of patient. So they came up with this thought that for most individuals, you don't need to retest at any point, because once you're positive, you're symptomatic. After a certain period of time, you're non-infectious. This is not a latent virus. This is not something, if you have an immune system, you should be able to fight it off and clear the infection. This is not applicable to every single patient. For most individuals, you do not need to retest. And this is based off of data. They have published data that show that you can be RNA positive for a long period of time after you're initially diagnosed. But after about day 8, after you've had the onset of symptoms, the ability to culture virus drastically reduces, and culturing virus as a surrogate for transmissibility. And this has been replicated through other studies as well. This particular study basically showed that this was a larger study with about 129 patients that are hospitalized, but there were several who were severely ill. And they showed that they could culture virus up to day 20. And this was the information CDC used to develop that particular guidance. But this has just been an interesting discussion in trying to help everybody understand what test positivity actually means. And it is to help diagnose pre-symptomatic and asymptomatic currently infected patients. It is not so helpful once you've had the disease to continue to test the patient. Now switching gears a little bit to COVID-19 and pediatrics. As Bonnie mentioned, AAP has a lot of good information specifically about pediatric patients. As of now, over 500,000 children have been diagnosed with COVID-19 in the United States, and it represents about 10% of all positive in the United States. Mortality in children has been very low, thankfully. So this is some of that information. this is a distribution of the percentage of positives in children across the whole United States and depending on the state. So California, we have about 10% of our children being positive among the whole population. But as you can see, the distribution is very interesting again. New York City and New Jersey have about 3.5% of their total positives as young children, whereas as we go up, the percentage of positives suddenly increase in these states. I don't think we know exactly why. This is the cumulative number of cases in children, and the dark blue represents the higher numbers. And cumulatively, as you can imagine, California does have high numbers of children infected, but this is another look of the same information, which is essentially percent increase in infections. And you can see that California is doing well in that area. In terms of clinical presentation of COVID-19, incubation period for children is similar to adults, 2 to 14 days, but most people get sick by day 6. And this is true about children as far as we know. And the presentation can be very wide, from asymptomatic to critically ill. The thought, and we don't know this very well because children are not as well tested, but the thought is that most children actually are in the asymptomatic to mild category, and only a small number of children actually are severe to critically ill. The symptoms of COVID-19 in children are similar to adults. It's a primary respiratory illness, so you do have the upper respiratory infection symptoms, lower respiratory tract infection symptoms, but interestingly, a lot of children also have abdominal symptoms. But otherwise, it's very non-specific. It can seem just like influenza or group A strep or any of the other illnesses that are very common in children. This is from CDC, which published information in pediatrics specifically, where they talk about how children comprise 22% of the US population. In their data, actually, only 7.5% of all cases are in children. This is from AAP that I took and put it as 10%. But the number and rate of increase in children has increased later as we come through the pandemic now. If you remember, in March and April, we were still seeing 1 to 2% of children were out of all of the infected population, but we do know now that that number is higher and probably higher than what we currently know. Hospitalization rates are significantly lower in children, which goes to speak that most children are probably handling the infection quite well. Although the rates of mechanical ventilation and death in children is far lower, 1 in 3 children who are hospitalized with COVID-19 are admitted to the intensive care unit, which is similar to adults. In terms of comorbidity, this again, we don't know exactly in children, but if you were to consider adult comorbidities like obesity, hypertension, diabetes, chronic lung disease, these are probably still important in children and may increase their risk for severe illness. However, we have had experience where severely immunocompromised children, children with cancer and organ transplant have done actually quite well with COVID-19. A word about multisystem inflammatory syndrome. It is a post-infectious phenomenon. This is the case definition, and it is a reportable illness. It can be quite dramatic in its presentation, can present as cardiogenic shock, but likely it has a wide spectrum. And it's just interesting to see the different inflammation complications that do not actually meet MIS-C definition that we have seen in our hospital and potentially others in the pediatric world are also seeing. The good news is that the number of MIS-C cases are small, so 792 as of September 3rd, which is 0.1% of all children infected. So that's good. However, as you can see, 70% of the reported cases have occurred in Hispanic, Latino, or non-Hispanic Black children. Most children with MIS-C develop it 2 to 4 weeks after the infection with SARS-CoV-2. I won't go into testing, isolation, labs, and imaging in children. Testing and isolation is very similar to adults, so not a whole lot to talk about. Labs and imaging, again, very non-specific in children, just like any other viral illness. So nothing that is very pathognomonic for COVID-19. A little bit about management. These are landmark papers that have come out about remdesivir and how you can use 5 days of remdesivir and equally efficacious as 10 days, and how it's helpful even for moderate COVID-19, how dexamethasone, this is the recovery trial, how dexamethasone has improved morbidity, mortality in severely ill. All of this are really in adult patients. And so in children, first of all, there are no FDA approved drugs, and this is true about all, but also for children. And based on preliminary data, remdesivir can be used for children with severe disease, however, and we have to acquire it through emergency use authorization. This has been changed very recently to you can use it for any child that is hospitalized, not just severe disease. And for other modalities of treatments like immunomodulatory agents, there is insufficient data to give guidance. This is per NIH treatment guidelines. This is our institution's treatment algorithm. This was developed by Dr. Hayden Schwenk from our division with Laura Bio, our pharmacist, and all of our infectious disease division. Basically, all institutions have some algorithm of this sort, which helps us use some amount of the adult information to make decisions in children. So I think that has been, as an infectious disease physician, we have faced is how does this translate in children? And 94% oxygen saturation in a child is not necessarily the same as in adults. And so when that cutoff is used for several of these interventions, how do we use that in children? And there is obviously the changing national guidance and the fact that things like remdesivir are common resources that are scarce for sure in downstream. And so we have to continue to be judicious about the use of these common resources. About LPCH, we have had a few, not a whole lot, but about 47 total pediatric inpatients. And this has been the numbers, total numbers. And as you can see, July was bad. And so this is the Santa Clara Department of Public Health. And if you can look at our graph, it exactly mirrors the local epidemiology. And this is the age distribution. Our youngest child, a baby, was 2 days old at the time of presentation, doing very well. The older population have been primarily hematology, oncology patients who have pediatric malignancy, but this is the age distribution. And about ethnicity, 41 out of our 47 patients were Latinx, and so speaks to what we're seeing overall in terms of that distribution. And health status, so a lot of the children that were admitted did have underlying severe chronic medical conditions. So talking about heart transplant, lung transplant, renal transplant, oncology, stem cell transplant, we've had a wide range of other comorbidities. But this is what is interesting. Our patients, most of them were asymptomatic. This is because we test all inpatient admissions and they were found to be positive. They came in for a completely different reason. Only 4 out of our patients actually were moderate to severely sick. We have had no mortality. So this is the distribution. And in terms of reason for admission, although COVID was the reason for admission in 34% of the patients, it was because they had an underlying medical condition that would easily make them more sick, like they had severe pulmonary hypertension or something like that. That's what brought them in. But really, as I mentioned, our pediatric patients have tolerated having COVID-19 fairly well. Thank you, and I will leave you with this. Please get your influenza vaccine.
All right, thank you, Roshni, and thank you both Bonnie and Roshni, and really a tour de force. I know you must get up at 4 a.m. every day to update your slides because things are moving so quickly. And thank you so much for sharing links. We'll make sure, obviously, that this Grand Rounds, like all of them, the video and the slide will be disseminated widely. So the questions have been outstanding. I'm going to run over time because I think we can get these answers recorded. We understand, of course, that some people will need to drop off. Most of the comments started out with or most of the questions started out with a comment that said, "Thank you for the great talk." Okay, will the MMWR report about daycare with the MMR report about daycare transmission, would you recommend that Stanford WorkLife and the university change their recommendations for children wearing masks in daycare on campus, or other changes that should be made for kids and teachers to remain safe? So I think the first question is, what are the current recommendations, and then should they be changed?
Yeah, so unfortunately, the daycare centers aren't actually, they're not Stanford employees. I don't know exactly what the recommendations are. I did go over them early on, but frankly, I can't remember what they are now because we've changed quite a bit. But I do think that our daycare centers have been quite safe. I do think that we should recommend masking of kids over 2 years of age are absolutely capable of tolerating masks. And clearly masking helps, clearly isolating if somebody in your household is sick. So not coming to work sick, masking, and then really avoiding secretions if possible from kids would be the most important recommendations. And I have looked at the VA and the Stanford daycare guidelines. It seems like years ago, but it was probably in May or June. And they did a pretty good job of really supporting all of the guidance. I don't know that there have been any cases. I haven't heard of any, but there may have been, maybe there were, but I just haven't heard of any. So I think they're doing a very good job.
Okay, thank you. Will the Stanford dashboard differentiate undergraduate versus graduate students? Some question about maybe differences in compliance with mask wearing and other guidance.
Yeah, right now we only have about 600 undergrads on campus. As you know, the undergrads haven't come back, and that dashboard will be modified as they come back over time to reflect differences, I think. We don't want to identify individuals, so we're trying to aggregate the data.
And as I recall, that dashboard is updated weekly, right?
Yes.
Yep. Okay. How has the virus changed over time, and what are the implications?
Well, of course, every virus mutates. I don't think we have any evidence that we know the virus is mutated way back. Well, obviously, there's actually a couple websites that track genotypes, and it's very interesting to see them. But really, the main genotype change occurred from Europe to New York back a few months ago. And the difference functionally in that virus is that it the mutation stabilized the trimer, the S spike protein trimer that actually attaches to the host cell, and it allowed it to attach more firmly, because most of these trimers will try to attach the cell, and most of them fall off, don't make it. So it has made it more stable. And so the question is whether it's more infectious, and we have not really had any evidence that that's really changed the virus infectivity, certainly not the virulence. But there have been no other major genotypic changes that have indicated a change in virulence or lack of virulence for that matter. So, and those are tracked on a regular basis. The BioHub has all of our samples here at Stanford. We are looking at some genotypic changes in the virus that may actually be related to different triggers in interferons and other cytokines, but those are research data, and we don't really have any definitive biomarkers at this time. But certainly we're working through the Mark Davis and I have the Human Systems Immunology Center. We pivoted and got Gates Foundation to fund some of that money for COVID related work. And there is some evidence that we're starting to see signals that may be biomarkers for risk for higher inflammatory responses, but nothing really firm yet.
Okay, a really important question, and that's about testing vaccine in children. I'm pretty sure that neither of the big trials, Moderna or Pfizer, is enrolling children, and we don't know what their plans are for enrolling children. Whereas AstraZeneca, I believe, plans to open a trial in in the US that will be enrolling children.
Yeah.
So is that the most up to date?
Right. Well, so on the Red Book Committee, I have two people, Jim Campbell from University of Maryland, Flor Munoz from Baylor, who are writing the NIH and the COVAX CEPI pediatric and pregnant women protocols and guidelines. It doesn't mean they're going to be implemented right away, but they have protocols ready to go. I just spoke to them yesterday morning, and those look good. David Kimberlin who's the Red Book editor, and I wrote a 3-page letter specifically about what we thought our bar for safety and efficacy data should be for any licensure. And we submitted that to the AAP leadership because we thought that it would be best coming from them. They're reviewing that. We're hoping that they'll publish that letter. And we're adding in there that pregnant women and children should be included in trials as well. But at this point, they are not, clearly, as you see from the data, they're not the highest risk population, but we do need to have plans for children and pregnant women to be tested. And I think that the plan is there. It's just not clear when that will happen.
Thank you. So a question that we often get that I know the answer probably is it depends. But would you recommend that children under 5 do virtual schooling or home care rather than daycare?
You know, I think little kids are probably at lower risk of transmit. I mean, I didn't show you the data from last time, but there was a Korean study of over 38,000 people looking at household and non-household transmission, and kids under 5 were much less likely to transmit in their households than any other age group. Not clear why that is. It could be a bias, and maybe they were less likely to transmit. They were less likely to be symptomatic, and maybe there was asymptomatic transmission. But I think what's looking likely is that young kids, even though they don't handle secretions well, can actually, if you're careful around them, you can handle them well and not. I mean, remember the 8-month-old who infected their parents, but obviously you need to be careful not to be close to facial secretions. So I think daycares and preschools should be safe as long as the schools have the resources to distance and wear masks and all of that.
All right, a follow up on the vaccine question and touching on your health equity component of your presentation. What can we do to increase study participations in clinical trials for the broader demographics needed?
Well, you know, the companies say that they're devoted to this, but in fact, I just got on my site visit initiation yesterday, and all they do is ask you, well, are you going to be able to enroll these populations? And you just have to say yes or no. Fortunately, we have a large Office of Community Engagement presence, so we have enough Latinx populations here. We have Native American, urban Native Americans here. We have just gotten potentially a grant to work with our Lakota colleagues in South Dakota and see if they want to get involved with vaccine trials. So it can be done, and the companies are asking for people to emphasize that. They're also asking for people to emphasize in vaccinating people over 65. And so the sites can say, yes, we'll do it, but if they don't, they're not going to hold them. I mean, I don't know what kind of accountability there is. So it really is up to us to advocate for those populations.
Yeah, thank you, Yvonne. I think it's so striking in your responses that you are the leading voice in so much of the studies that are needed to inform or either advocating for these sort of initiatives. Okay, important question. Can you catch it more than once, and does it present differently, and does the prognosis change?
Yes, you can catch it more than once, probably. I mean, I'm not, as all of us infectious disease people know, coronaviruses are around a lot. Mucosal viruses in general tend not to confer long-lasting immunity. I don't know why, but we know that you can catch RSV over and over again, even though it doesn't mutate. We know that coronaviruses come back. We already have evidence of potentially of at least 2 reinfections with new serotypic strains. So we think that for natural immunity, 4 to 5 months might be a limit, but again, we don't know. And whether the adjuvanted vaccines or even the non-adjuvanted vaccines lead to longer protection, we don't know. The other opportunity, I think, are monoclones. And as I said, we just enrolled our first monoclonal patient yesterday, but that's a traditional monoclone, so it'll only last about 28 days. If the companies can attenuate the FC fragment, you might be able to get a long-lasting monoclonal, which could last up to 3 or maybe 4 months. So whether those confer, well, they can confer immunity, whether they confer neutralizing long-lasting immunity would be, we don't know. And whether they confer immunity against disease or infection are 2 different things. So if you're prevented from getting infected, that's better. But if you're prevented from getting disease, that's fine, except then you may still be infectious to others. So we're still learning all of that.
Yeah, thank you. So can we, the medical community, actively spread the message in one voice that the masks prevent spread as well as protect the individual? And I think the widely publicized letter signed by all of our faculty in epidemiology, immunology, and pediatric infectious disease did that. But do you want to comment any more about how we can spread the message in one voice to do that?
Yeah, I do think that, this has become very complicated, very opinionated, politicized and everything. But I think generally people know that mask has been protective, and there have been a lot of things, especially in the medical setting. We do know that wearing appropriate PPE, which includes the mask, has been protective to the healthcare community. So I do think that the letter does talk about it, but we should continue to reiterate that message. Definitely a small thing to do to protect each other.
Well, one non-aligned way to do it is to just post Robert Redfield, the head of the CDC, just saying masks are probably more effective even than vaccines at this point in preventing spread. So we could always just say, you know, the head of the CDC does it, and so far we trust the head of the CDC. And I think we should all believe that masks really work. There's so much evidence. Now, they aren't 100% effective, but they're pretty close if you use them properly. That is, you don't have them under your nose or you don't have them dangling off your ear. They have to be worn.
Thanks. Somebody asked for a future talk on the data on pregnant patients in COVID-19. Alexis Davis, Nadia, our maternal fetal medicine colleagues, did a wonderful grand rounds on this in June, I believe. It's posted on our website. We'll refer people there unless you feel like there's significant new data that changes the messaging from that presentation. What do you think?
Yeah, unfortunately, I'm not aware of any new data among pregnant women at this time, but yeah, there's certainly, we've funded a couple of projects through my dean's office on looking at CPQCC and CMQCC. I know that Natalie Aziz and one of her fellows are going to be looking at antibody incident prevalence and seroprevalence of disease in our LND population here at Stanford, and the data looks very good. They submitted an abstract and are working on a manuscript.
Okay. Roshni, I think this is for you, and that has to do with the benefit of keeping exam rooms closed for 60 minutes before disinfecting procedures after a suspected patient. Is that currently advised for our facility?
So we do have specific guidance around that. So if a patient is COVID-19 positive, or if the patient is currently being investigated and you're performing an aerosol generating procedure, definitely that 60-minute rule applies in those instances. But if a patient is none of those and having, coming in for a regular checkup and has some symptoms, but you're not performing an aerosol generating procedure, the recommendation would be to keep the door closed during the examination and then do the regular cleaning, but does not require a 60-minute closure of the room because you have not performed an aerosol generating procedure. So it's a little different than, say, TB and measles, where N95 is directly connected to room closure. This SARS-CoV-2 is not the same. So we use the aerosol generating procedure as the way to decide about the room closure.
Yeah, thank you for such an evidence-based approach. Bonnie, any information regarding the safety of one vaccine versus another type?
No, the safety signals so far are pretty good. And I think what the safety signal we saw with the AstraZeneca vaccine, you're enrolling 10, 20, 30,000 people, you're going to see a safety signal. Grace Lee is actually going to be leading, that's the safety working group for the ACIP. And they generally follow very stringent rules. But there will be some signals. The question is, what does that mean? And CDC has some really nice real-time analysis that they've innovated in the last few years, so that they can look at safety signals in real time, compare it to general population, compare it and see if it really means that the trials need to be stopped or completely abandoned. But so far, the vaccines look pretty good.
Yeah, thank you. Bonnie, you predicted that most of your questions today would be about schools. That is the case. I'm going to try to move through these quickly. If I'm choosing to keep my kids home from school and daycare, is it recommended to not bubble with a family whose children go to school and daycare where masks are encouraged but not mandatory?
Well, I'm not sure how, again, it's hard to answer that question because I don't know how many kids, how they, you don't know what people are doing in their house. It's kind of like the old HIV when who is the contact of your contact of your contact, right? So I don't know what that circle looks like. If it's a really tight circle and you feel really confident with them, well, there's always a risk, right? Look at the daycare center outbreaks. All three of them originated from staff members, two of whom we knew had a staff member at home who was sick. So it just depends on how much you trust the other people. I would say that probably going back to school is maybe, depending on the school district, may not be any higher risk than hanging out with another family who might, you don't know, you can't track everyone's activities. So
okay, so
it would be great if we had cell phone based apps to track people, but
yep.
That's a little bit of an invasion of privacy, I think.
Yeah, so we have a couple more questions, which I think speaks to the ongoing participation in this, but I'm going to say no more questions after the ones that are currently posted. Another one that I think is going to be difficult to answer, and that relates to the importance of on-site health services at schools.
They don't exist. I mean, how many schools have school nurses? I think there's a real disparity. I don't know how they're going to do it, frankly. It depends on, again, you have to talk to your school district. I've been talking to school supervisors, board of supervisors, et cetera. They just don't have, a lot of them have resources. So one of the things, another disparity is that private schools have everything. They've got nurses, they have, all kinds of support. The public schools, not so much. So, and that's unfortunate, but it's, that's the way things work. And so I think if, I would advocate for health services at school, but the reality is those have never really, we got rid of school nurses a long time ago. So if there is a school nurse, frequently it's a county-based or a district-based school nurse. That doesn't mean you can't have protocols in place for non-health care workers at schools to be able to follow certain protocols. So I think as long as you as a, take away your healthcare worker hat, just as an informed parent, say, what is it that you will do if my child, so when your kid goes to school and they need an inhaler, what happens? This is pre-COVID. Did they get their inhaler? At our schools, when my kids were little, they had to bring their meds with their name on it, and there were instructions in there and when they could get it and who would administer it. By the way, speaking of inhalers, make sure you have an MDI if you're using inhalers, because that's going to be a big safety issue for the school. But I think, whatever you were doing before, I think you just need to find out what's going on now. At schools, I would say the main thing is really to make sure the kids, if they get sick at school, can be referred back to their home and their provider if they get a fever or start having symptoms. The idea is to get them out of there as quickly as possible and into care.
Okay. Can you comment on the political pressure on the CDC, which could affect the trustworthiness of their recommendations? And good thing we have the AAP.
Yeah, the AAP is non-aligned, and we will speak truth to power. As you say, I think we are just going to follow the data. I have to say that my colleagues at CDC are doing a fabulous job, despite all of the pressure. I mean, everybody's under pressure, right? I don't think but I think they are facing significant pressure because this is a pandemic that people want to end. They will do everything they can, but the AAP, and we've communicated this to ACIP, for which we are liaisons. If we don't agree with them, and frequently we don't, I mean, with HPV, sometimes we get into little tussles around, well, we don't like that word or this recommendation. So sometimes we don't agree with them anyway, but this has much more consequences for disagreement. But we have told them, look, if we don't agree with you, we may not support your recommendations. And they know that. We have that long-standing relationship. We meet with, well, not lately. We do meet with them once a month to go over pediatric specific issues that the AAP and the Red Book Committee may have. So we have a very good relationship, and I have all the confidence in the world for our members there, our CDC officials.
Thanks, Bonnie. And then something that was an active topic conversation with the dean and among all the chairs this morning, and this has been more around the safety of college athletes and maybe even the cardiac issues in particular. And I know you're very active in those conversations. How should pediatricians respond to parent questions regarding high school sports?
So there's a guidance that's going to be coming out, one on school guidance. It's embargoed. I can't say much about it. It'll be out in the next couple of days. There's also, which I'm not sure I agree with, but there's another one on MISC, which kind of leads to the school-based, because the pediatric cardiologists are worried about the myocarditis. It turns out that there's a German study of adults who had a wide spectrum of disease, and 30% of the adults had clinical and echocardiographic evidence of myocarditis. Or EKG evidence of myocarditis as well. But the clinical significance of that is unclear, because if you're picking it up prospectively, it's hard to know how much baseline disease there might be in anybody. And so we don't know what that means. So what the AAP is recommending for MISC patients is that they refrain, if they have evidence of myocarditis, they not engage in strenuous activities, including sports, for at least 6 months, and that they're followed up by a pediatric cardiologist. And then the question is what to do after that. We just don't know. We're trying to figure that out. Now, the other issue around school guidance for healthy kids is whether or not kids who are sick. So if a child has COVID, the recommendation is to just keep them from strenuous athletic activity if they have, I think if they have evidence of myocarditis. But the question right now, which hasn't been resolved yet, again, still not resolved, what about the asymptomatic kid? Do you work them up? If they have COVID, I would probably say, yeah, work them up, because you don't know if they have asymptomatic disease. And then the question remains, if they do have asymptomatic myocarditis, that is, they're not sick or symptomatic, but they have evidence of inflammation, I would more likely than not keep those kids also out of strenuous activities for at least 3 to 6 months, pending additional natural history studies. I did get you heard Mary this morning, Bob Harrington, who was chair of medicine, former president of the American Heart Association, said he would not do the same for exposed but uninfected children. So if they're exposed and not infected, then you don't need to do the workup at that point, only infected kids.
Yeah. Okay, I want to thank the hundreds of participants that stayed with us right up to the very end. And I want to thank Bonnie and Roshni on behalf of all of us for your extraordinary work. So thank you, everybody.
Thanks, everybody. Have a good weekend. Stay safe.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.